Good afternoon, Rotarians, friends, Rotarians, guests, and those who are joining us via Zoom. Welcome to the April 14th meeting of the Rotary Club of Louisville. I'm Jean West, owner and producer, Faces West Productions, club president, and a Paul Harris Fellow. To provide our invocation is Chris Manzo, owner of SNDBX Design Collaborative. What does that stand for?
Sandbox. Sandbox.
Can I just say sandbox?
Sandbox. Absolutely.
Okay. Sandbox.
Awesome. Thank you. Thank you, President West. Let's bow our heads. Creator God, we take a small breath out of our busyness and distractedness to thank you. Thank you for this spring day that is glorious. Thank you for the food that we're about to eat. And we thank you for those who have prepared it, the farmers, the soil that you create to make the food. We thank you for the fellowship in this room. And we ask that this next hour be used to radically impact our community, Louisville, in ways we can't even imagine at the moment. That would be radically impacted for good for the years to come, just out of this next hour. We ask that. We also ask for peace. We pray that the armies of the world would cease their confrontations and that people could go back to their lives. Bless this hour and our time together. Amen.
Thank you. And now to lead us in the pledge and four-way test is Ginger Wallace, Director of Development at Parks Alliance of Louisville and a Paul Harris Fellow.
Please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. And now the four-way test of what we say, think, and do. Is it the truth? Is it fair to all concerned? Will it build goodwill and better friendships? Is it beneficial to all concerned? Thank you.
Thank you, Ginger. You may be seated, Rotarians. Blah, blah, blah. It's always our pleasure to welcome guests, Rotarians. If you would take this time to approach the mic, introduce yourself first, and guests, will you please stand when you are introduced so that we can salute you?
Madam President, Brett Corbin from the Corbin Financial Group of Raymond James. My guest bailed on me this week, so she did not attend. However, I have 2 tickets for Keeneland tomorrow that I can't use. Free to a good home.
Whoa, wow, free. That's awesome. Thank you, Brett. Shh. Faites attention, s'il vous plaît. Faites attention.
My guest today is my husband, Dr. Fred Seifert.
Welcome.
Delene Taylor, Executive Director of the club, and she's not a guest, but I think this is her first time to join us in a while. Welcome back, new member Jane Walsh with the
Jane. Thank you. Welcome back, Jane. And guests, if you'd like to learn more, and we don't really have any guests, but anyway, Craig Sherman is going to be over at the What is Rotary table for any questions about Rotary. Time now for the Cajun culture class. Now, when you start a job in Louisiana, or even if you do business there, especially in the media, you are given this list. Really, this is a real thing of names for practice in pronouncing them correctly. So I picked out a few. Let's see if we can pronounce these names. All right, all together. Number 1. Arsenault, very good. Number 2. Aucoin. Right. Number 3. Barrio. Yeah. Number 4. Bro, that one's easy. Number 5. Chasson. Number 6. Domain. Number 7. Hebert, right. And I know a lot of you know Mark Hebert, who is the reporter. I cannot tell you how many times I had to stop and think, not Hebert, not Hebert. Number 8, Melançon. Number 9, Robichaud. Number 10, Thibodeau. Very good. All right, you all passed the Cajun culture class today. All right, now at this time, the Rotary Lifetime Service Award is given to Rotarians who have demonstrated across their years of service faithful and consistent adherence to the tenets of the 4-way test in pursuit of Rotary's values in one or more of these 4 avenues of service: club service, vocational service, community service, or international service. This year's recipient indeed exemplifies Rotary's values in all of those ways and is an exemplary model of service above self. And here to present the 2022 Lifetime Service Award is Karen Morrison, President, CEO of Gilda's Club Kentuckiana and Youth and Education Committee Chair.
A Rotarian since the 1980s, when few women were admitted to clubs, our recipient of this year's Lifetime Service Award was initially drawn to the idea, the big, hairy, audacious goal of polio eradication. So she joined Orange County's oldest club in Santa Ana, California. When her work took her to San Luis Obispo, she switched clubs and later served as that club's president before returning to Santa Ana, where she served as chair of the International Committee and had the life-changing opportunity to participate in a polio immunization trip to Ghana. That trip led to another with a member of the Accra Club up to the Annam traditional area, where she met with elders there to discuss what would become a multi-year relationship between Accra and Santa Ana clubs. She later served as president of the Santa Ana Club, where she challenged them to make the membership more diverse to better reflect the business community of Santa Ana. Coming to Louisville in 2005 to lead the Foundation for a Healthy Kentucky, she joined this club, where she has been a member since. She first served on the Saving Lives Worldwide Committee and later helped negotiate the merger of that committee with the International Committee, on which she has served as vice chair and chair. She's also chaired our club's Invocation Committee, Foundation and Grants Committee, and has served as the member of the Board of Directors and the Finance Committee. She's a Paul Harris Fellow many times over and a member of the Paul Harris Society. She currently serves as vice chair of the International Committee, as well as a member of the Foundation, Community Investment, and DEI committees. At the district level, she serves as the chair of Rotary Friendship Exchange, where I had the honor of joining her in a trip to India a few years ago. Her service extends beyond Rotary, far beyond Rotary, through our local and global community. She's served on many boards and is an active member currently of Leadership Louisville's Encore program. By now, most of you know of whom I speak. Please join me in congratulating the one and only Susan Zepeda. Susan. Susan, please accept this well-deserved recognition of a lifetime of service, which shows no signs of slowing down, but rather continues to grow in your diverse commitments and the impact you make, not only on all those you serve, but on those of us who have the honor to serve beside you. Congratulations.
Thank you, Karen. Thank you, President Jean. Thank you, Rotarians. This means a lot to me. Being a woman of a certain age, I've been the first woman in a lot of rooms and at a lot of tables. I've been the first woman to lead a number of organizations, but this means a lot to me. I've always hoped that my actions made it easier for the people who came next. For over 30 years, as Karen let that cat out of the bag, Rotary and family have been my guiding lights, if you will. They've helped steer me through good times and bad. And it turns out that the four-way test is a really good navigation tool. Thank you very, very much.
We were hoping she'd be surprised. That was awesome. Yeah. And now I would like to bring to the podium Luke Schmidt. Oh, I'm sorry. No, a little bit to share about his trip to our project in El Salvador. That would be Rick Harnett, who is a Lifetime Service Award recipient himself. Paul Harris Fellow, ×8, a major donor, as well as chair of the District Rotary Foundation Committee and many, many other roles. So here's Rick Harnett.
Thank you so much, President Jean. It's a real pleasure to have this opportunity to report to the club on two projects that we have been working on for several years in El Salvador. I had an opportunity to visit in February of this year. Before that, our last visit was in January 2020, when Susan Zepeda and Alex Novak and I, in Alex's, in my case, with our spouses, were able to visit to see the work being done in two important areas. One, a little mountain settlement high in the mountains that had no decent water to use at all. And the second project is a major project to put decent sanitation in a series of rural schools near Armenia. Here's the Las Graditas project. That creek was the only source of wash water. And it was so polluted it could not be used for drinking. The residents of the community had to basically buy bottled water and use it extremely sparingly because it's not at all cheap to be able to use it. So they contacted the local Rotary clubs who put together a project to drill a deep water well, build in a pump house, and then send the water up to this storage tank that has just been completed. And then from there, it will be piped to the individual homes. And the next slide, you can see the members of the community digging the trenches for those pipes. This is not a project that was just given to them by Rotarians. This is their project. They wanted it, they've worked on it and contributed to it with some help from Rotary clubs, ours in a leadership position, but 4 other clubs in our district also contributed money. The Lexington Club contributed money. Clubs in Canada and in California contributed to this project as well. The community residents know they're going to have to pay for the water. Their water is all going to be metered. So if anybody uses too much, that charge will come to them. They're going to be very responsible about it. The last steps in this project are hygiene training and then observation to make sure that the provision of decent drinking water is going to make a difference in the health and the school attendance of the children. The other project is called Toileton. That in Spanish, that's the big toilet. And it's an effort to bring decent sanitation facilities to a whole series of rural schools. You can see from the beginning that what's there now is generally pretty basic and not at all healthful, since it's all open and any flies and everything else can get in there. It's a nasty situation in many of those schools. The schools themselves are pretty decent. They're open, they're airy, they're colorful, that the state has built and provides for the staffing of the schools, but it doesn't provide very much in the way of a commitment of equipment or school books, and certainly not in terms of kitchen and bathroom facilities. And of course, that doesn't help the girls stay in school. You've got to have decent health facilities if you're going to get girls well into their high school. And some of these schools do have middle school level classes. We have visited this past February, 7 schools, 4 where the work has been completed, 1 where the work is underway, and the next 2 on the line. So we could see what a desperate situation some of those are in. Here's the work being done in that one school to dig for a biodigester and a septic tank system to provide for that. They've also put in an elevated water tank. They do get city water. It's not particularly good quality, but it's irregular in terms of its provision. So the elevated tank will make sure that the school has a constant supply. Here's the finished product. I just got a report last week with many more pictures than this, showing the quality of the work that's been done and the role of the local Rotarians and community members in keeping it going and making it really a nice, attractive, beautiful, safe, clean area. And you can see particularly in that picture on the right, I'm not sure how well it shows up, there is basically a bidet facility for those teenage girls who need a little extra cleanliness during certain times of the month. It can keep them in school. So this was a wonderful trip that was made a lot more pleasant by our local Rotarian hosts who provided us a place to stay, who drove us around on some arduous back roads to get to these schools and see the work that is being done, how your money and the money you give to the Rotary Fund of Louisville and to the Rotary Foundation is making a difference in the world. Thank you.
Thank you for that update, Rick. Earth Month is coming up. We have 2 big projects that you can participate in. The Kentucky Waterways Alliance, it's Earth Day, Sand Island Paddle and Cleanup. This is really a lot of fun, guys. You should think about it. Take place at Shawnee Park Boat Ramp. It's next Friday, April 22nd from 9:30 to 9:50. I'll be speaking there along with Mayor Fisher and others. And then we paddle to Sand Island for cleanup. Then the next day is our Rotary Saving Our Rivers Service Project next Saturday, April 23rd from 9 to noon. We will be meeting at St. Mark's Episcopal Church parking lot on Frankfurt Avenue, and then marking the sewer storm drains along the Frankfurt Avenue area. Okay, the neighborhoods and Frankfurt Avenue, marking the storm drain with these stickers that show that if you dump into the sewer at that place, it goes right into Beargrass Creek, which goes right into the Ohio River. So there are postcards at your places on the table. Please take them, sign up we need volunteers to help with registration and just doing, the stickers. It's a really easy thing. Okay, I'd like to now welcome past President Luke Schmidt, President of L.B. Schmidt Associates, Paul Harris Fellow, past President of the club, Chair of our Community Impact Committee, with a quick update on our West Louisville housing project.
Thank you, President Jean. It's a pleasure to be here, and thanks for all of your support of our project. On behalf of my co-chair, Denise Sears, who's not here today, I'm pleased to take just a moment to provide all of our members with a quick update on our fundraising campaign for our West Louisville Housing Initiative. Our goal is to raise $5 million, all of which will be used to fund loans administered by our fiduciary partner, Park Community Credit Union, for first-time low and moderate income home buyers in low and moderate income census tracts in West Louisville. Home ownership is something that many of us take for granted, but it's a huge deal in West Louisville. And because of the historical impact of redlining and current federal regulations, many buyers cannot qualify for conventional loans through banks. Many buyers, however, have proven their ability to make payments by renting property, often making monthly rental payments 3 times what a monthly mortgage payment would be. The Rotary Club of Louisville, your club, our club, has found a unique way to solve this problem. We are establishing a dedicated pool of funds in an account at Park, which will be used to extend loans to first-time home buyers. Park, which holds several important banking designations, will be able to qualify buyers and extend loans that no other financial institution can do. And our fund becomes a revolving fund over time as payments are made directly by the home buyers back into our dedicated account. Initially, we believe that we will be able to put 60 families into their first homes with more to follow. The Federal Reserve Bank has told us that our program is the first of its type in the entire United States. Complete information is available in the flyer at your seat. And we're asking, as we did back in January, we're asking each Rotarian to consider donating $500 a year for 5 years, or what we call 500 for 5. If each of us does this, we'll raise $900,000. Many Rotarians have already answered our initial call back in January, and we truly appreciate that. And we'll soon be publicly recognizing everyone who has pledged. So now for the update. We started in January with 2 early pledges totaling $167,000. As of this week, I'm very, very pleased to tell you that we have signed pledges totaling $1,091,400. That's a terrific first report, and we hope to have a few more to bring. So my thanks to each of you who have pledged so far. Please join us by completing the pledge form at your seat. Return it to me as soon as possible. Your donation will be matched by Park by 20% and is fully tax deductible. Thank you. Thank you.
Rotarians, you should be proud. I mean, this is a transformative project, I mean, the first of its kind in the country. So thank you all for your support. Luke, Denise, thank you for your leadership in this. Now, our speaker, Dr. Michael Joseph Imburgia, graduated from Southern Illinois University School of Medicine in 1983, specializing in cardiovascular disease, internal medicine, but it doesn't stop there. Also specialized in adult echocardiography and nuclear medicine, and was actively involved in research as a certified clinical principal investigator for the Association of Clinical Research Professionals. He spent many years as a medical director of the outpatient cardiovascular ultrasound lab at Baptist Health Louisville before retiring, but it doesn't stop there. He is the founder of the Havahart Clinic in Louisville, providing cardiovascular care to the indigent, and he'll tell you all about that. But he's been known to come out of retirement to treat longtime patients like our Rotarian Erica Fields, who is ever grateful that you did so, Dr. Imburgia, and recommended you highly as a speaker to our club. So please welcome Dr. Michael Imburgia.
Well, all that stuff was a long time ago. And first off, thanks for having me. Anytime I get a chance to talk about our clinic and more importantly, healthcare disparities, health disparities in our country, I'm excited to do that. And I have a fair number of slides to get through but what I'm going to try to talk about is the state of healthcare in our country and talk about the disparities of healthcare in our country, and then try to tie that into what Havahart is doing. And I've been here for over 30 years. We started the Havahart Clinic in 2008. And 4 years ago, I went part-time at my job and worked part-time, volunteered part-time at Havahart. And in 2021, I basically quit my job and I volunteer now full-time at our clinic. And so what is the state of healthcare in our country? And, you know, unfortunately, we spend more on healthcare in our country than any other country. Yet we tend to have the worst outcomes. And I'm going to circle back to that. But if you look at how much we spend on drugs in our country, we spend far more for the same medicines than any other country pays for. When it comes to certain procedures, surgeries that we do, yet they're the same equipment, same results, same procedures. We spend an unbelievable amount more for those very same procedures. Valve replacement surgeries, bypass grafting, joint replacement surgeries. We just spend more money for the same thing. And this graph shows you what we get for that. So you would think that spending all that money would mean we got to be doing a heck of a lot better than everybody else, but it turns out our performance is the worst. We spend the most with the worst outcomes. And why is that? It circles back to what we spend our money on. We are great at treating a problem, and people come to this country to get treatment, but we don't spend any money preventing illness. And one of the reasons why our performance is the worst is lack of access to care. And there are many people in our country that just don't have access to care. And that's one of the reasons why our performance is worse. But so if you compare what we spend on healthcare to other countries, in reality, it's really close to about the same. And if you've never read the book Upstream, I would encourage people to read it. It's a fabulous book. But for every dollar other countries spend treating a problem, they spend $2 preventing the problem. In our country, it's the exact opposite. So total spending, we're pretty close. The difference is how we spend our dollars. They spend their dollars keeping their patients, keeping their population healthy. We spend our dollars treating a problem. And so some of the disparities that I'm talking about, the first is which is based on income and wealth. And I put this slide up here to show you the federal poverty levels. And before the Affordable Care Act, people weren't eligible for subsidized care unless they were at the 100% federal poverty level. That was extended to the 138% poverty level. But if you look at this, I don't know how somebody lives off $17,000 a year and is able to pay for healthcare. It's impossible. And you can't buy health insurance if you're a single person for less than $500, $600, $700 a month. And so you're going to spend half your dollars on health insurance that then you can't even afford to use. And I think it's important to see these numbers and realize what they mean. I mean, a family of four isn't eligible for subsidized healthcare if they make $40,000 a year. They'll spend $12,000 paying for health insurance. But how many people live at that level? And you all, it's a lot of people. In Kentucky, 33 to 41% of Kentuckians live at that under 200% poverty level. And that's not a lot of money. This shows the distribution of federally qualified health clinics and the kind of patients they see and why you need them. Nearly 70% of them live below the 100% federal poverty level, or at or below the 100% federal poverty level. And this is stuff that you guys probably understand more than I understand, but what's happened to income and wealth and the Gini coefficient, which I'm not exactly sure what that is, but it's increased every year since the 1970s. In 1978, the share of income going to the top 10% of earners was 33%. In 2014, it was 50%. And as you know, that increased even more, and it increased exponentially during the pandemic. The people with money got wealthier, the people without money got poorer. And low-income families where someone has had a cardiovascular disease, 10% of them will experience some type of catastrophic burden from that they will not be able to afford to pay for their bills. Poverty's been long recognized as a contributor to death and disease. In the 1970s, a 60-year-old man in the top half of income distribution could live 1.2 years longer than a man in the bottom half. At the turn of the century, it was 6 years longer. And in your county, in this city, there are parts of your community in the West End where they live 10 years less than the East End. And I always ask the question, how much is 10 years of your life? Life expectancy has increased 2.5 years for the top 5% income distribution. There have been no gains for the bottom 5%. We have the largest income-based health disparity in the world. Less than 1/3 of low-income workers obtain health insurance through their employers. So if you say, well, they get it through their companies, no, they don't. They don't get that. And low-income Americans have higher risk of behavioral risk factors. How does that equate when you look at income? And if you look at stroke, heart disease, and hypertension, look how dramatically those incidents go up the less money you make. The wealthier you are, the healthier you're going to be. Life expectancies, this is for every state. And the point is look at the poverty level and look at their life expectancy compared to those people with money, the wealthy. 10, 12, 15 years differences in life expectancies. So at Havahart, which again, we started in 2018, we now see people 5 days a week. Anybody who lives at or below the 200% federal poverty level pays us nothing. So if they don't have insurance, they pay us nothing. If they have insurance, we don't charge their deductibles or copays, because there are now 40 million people that are underinsured in our country. They have it, but they can't use it. My kids are part of that. My son's a well-educated kid. He gets paid. He works at the Shed Aquarium. He gets $18 an hour. If he needed to come up with $1,000, he wouldn't have it. So moving on, race and ethnicity in healthcare outcomes. And I'm going to give you an example because I think it's important to understand the patients that you see and that this is a real issue. And so we see probably 5, 6, 7, 10 of these a day. And a 63-year-old gentleman comes into our clinic, and in 2012, he needed surgery on his legs. And so he was seen by a cardiologist, and he had a stress test done, and that stress test looked like he'd had an old heart attack. He had his vascular surgery. Nobody arranged for him to follow up with anybody. Cardiology didn't have him come back. So he shows up in our clinic now 10 years later, and nobody bothered to ever work up the fact that he'd had a heart attack. Nobody bothered to take the time. Why? Because he's Black. He's poor. They didn't even tell him that he had an abnormal stress test. And now his trust in the system is destroyed, right? I'm telling him it looks like you had a heart attack 10 years ago, and nobody bothered to tell you about it. So again, if you look at the total population, and it's important to know this statistic, 57% of the people in this country are white. But if you look at the non-elderly uninsured, why non-elderly? Because if you're over 65, you get Medicare. And if you look at the uninsured rates based on race, again, look at the dramatic difference. If you're Black, Hispanic, or other marginalized races in our country, you're more likely to be uninsured. Roughly 1/3 of all African Americans report being personally racially discriminated against when they go to the doctor or health clinic. About 20% of African Americans said they avoided going to the doctor because they didn't want to be discriminated against. Mortality rate based on cardiovascular disease. It's declined for everybody, but still look at the marked disparity between Blacks and everyone else. Life expectancies. African American, Native American, all markedly less than other race. So what else proves this? And I could show you 1,000 studies that have been done over the past 50 years even that show this disparity. And it took a pandemic to bring out the disparity, and whatever it takes, great. But it's existed. I'm sorry, I'll get kind of passionate about this because it really, really bothers me. ICDs, life-saving defibrillators. And if you could extend that beyond 2011, but look at the difference between whites, blacks, Hispanics on whether they got a defibrillator that they should have had. The latest, greatest procedures in cardiovascular disease, percutaneous or catheter-based valve replacements, aortic and mitral, and what's called an occluder device. This study just came out in like 2020. Look at the difference between whites, blacks, and Hispanics. Additionally, approximately 25 million or 8.6% of the US population is what's called limited English language proficiency. So that 8.6% is at high risk of inferior care because nobody wants to spend the time to talk to them in their language. What about insurance status, health, and outcomes? And I'll give you another example. A 48-year-old gentleman who was found to have a severely blocked off valve and fluid around his heart, and he's going to need to have surgery. So we need to try to get him evaluated. Well, he's Hispanic, he doesn't speak English, and he doesn't have insurance, and he doesn't have any money. His only option is for us to help him fill out financial aid paperwork, try to get one of the hospitals in town to approve him for indigent care. But I can promise you, if they do approve him, it'll take 2, 3, 4 months to ever get that approval for him to get treated. But he doesn't have anywhere else to go. So how does that play out? Well, first off, I think people think that these uninsured people are just sitting home doing nothing. They don't want to, they don't want to do anything. But that's not true. I mean, almost 90% of them work. Why are they uninsured? The vast majority is they can't afford insurance. That's why they don't have it. What happens if you're uninsured? And this compares uninsured to Medicaid, because make no mistake, if you have Medicaid, there are not a lot of doctors and hospitals out there that want to take your insurance. It pays less. The patients are 10 times more complicated. But look at the differences. Didn't see a doctor, healthcare professional. Look at the difference between the uninsured and the insured. No usual source of care, uninsured dramatically worse. Postponed seeking care due to cost, uninsured Medicaid dramatically worse. Went without care, Medicaid and uninsured worse. And delayed getting their medicines, Medicaid and uninsured dramatically worse. Nobody wants to see them. Problems paying medical bills based on their insurance status. And again, it's really no different. But I'll point out one thing about this and the state of healthcare in our country. Even people with commercial paying, with commercial insurance, 46% worry about being able to pay their bills. That's ridiculous, is it not? But it's so much worse if you don't have insurance or Medicaid. What other characteristics? Of course, the majority of them are poor. The majority of them are Hispanic, Black, or other marginalized race. And currently, there is 11% of our country is uninsured. So what about the Havahart Clinic? So we see consults, follow-ups. We do all types of cardiovascular testing, ultrasound, stress testing, vascular testing, and we do that all pretty much free. And you won't see the uninsured rate up here a lot, but it's about 15% now. During the pandemic, thank God, they loosened the rules and more people got insured. But we're already seeing this year, since that went away, that's heading right back up. We were down to about 10% last year. We're already back up to 15% this year. But we're able to see up to 800 consults in 2021, which was huge for us. New patient uninsured rates in our clinic dropped significantly. They're going to head back up, as I said. Follow-ups, we're able to now access and give access to more follow-ups. And last year we saw over 2,500 patient visits in our clinic. Our federal poverty levels, around 80% live at or below that federal poverty level, which means over 80% of the people we see pay us nothing. But in addition, honestly, we don't ever turn anybody over to collections, so nobody pays us anything if they decide they don't want to pay us anything. So the number of patients that we have that don't speak English is 20%. 18% speak Spanish. And fortunately, we have interpreters and some interpreter phone type things, video things that we use. Percent people of color, and honestly, I'm dang proud of this. We're up to about 70% of the people that we see are people of color now. And that's great for us. It means that we're hitting the right group. If I was fancy enough, I would have put these zip codes on a map, but I don't know how to do that. So the cluster is downtown, West End, and South End. And a lot of people believe it's just the West End, but it's really not. It's the West and the South End. It's the largest Hispanic population in the South End of town. And we're happy to be hitting those groups. And this stuff just, years ago, I knew that data was important and everybody else uses billing data. So we created our own database. It costs us a lot of money to have somebody build it for us, but so we keep track of all of our own data. So the number of chronic illnesses, and I'm just going to point upon this because this is why people don't want to see these patients. A lot of doctors don't want to. So we see a younger population nationally. The number of people that have multiple chronic medical conditions, that is high blood pressure, diabetes, high cholesterol, whatever, is probably around 25%. In our clinic, it's almost 70%. It's about 60%, 67% have multiple chronic conditions. And trust me, they're a lot harder to take care of. An example is a 34-year-old girl that we saw who 4 years ago had a baby, and she developed a cardiomyopathy, weak heart muscle, after that delivery, which unfortunately isn't uncommon, but so she developed heart failure. And then shortly after that, she saw her 17-year-old daughter murdered in her front yard. And it was just tough for her to take care of herself, right? She's got these conditions but our system kept labeling her as non-compliant, and it had nothing to do with non-compliance. It had to do with her ability to deal with what was going on. And we failed. The system failed her. But they're just harder to take care of. They just require a lot more time, a lot more attention. Roughly 30% of the people we see have an abnormal depression screen. We do a score on them called a self-efficacy score. How able are you to recognize your medical conditions and treat your medical conditions and take care of them? And unfortunately, about 35, 36% of them are unable to do that. And then the reasons for the visits to our clinic are pretty typical. The cardiovascular practice, by far and away, chest pain and arrhythmia and abnormal EKG. So pretty much a normal clinic. And these are referring clinics. There's a lot of them. But 90% of our patients come from either federally qualified health clinics. And if you're not familiar with those are the Park Duval clinics and the family health centers. But in addition, a number of other non-for-profit clinics. A lot of people don't know this, but there's a lot of halfway houses that have clinics where people are transitioning from prison out to the community. There's a lot of addiction centers that have clinics. And so we get a lot of patients from those places also. And then that wasn't enough. How much time do I have?
It's 12:45, so about 5 minutes.
So that wasn't enough. And again, I'll go back to the upstream, read that book. You know, it's one thing to give access to patients that don't have access. And so that's what we did first. That's what you had to do first. But then the question was, if all of these populations are dying from cardiovascular disease, which is why they're dying. I mean, the life expectancy that's less is less because they die from stroke, heart attack at 2 times the rate of other people. And so we formed a health equity center, and we did it at the perfect time, February 2020. And we had to pretty much shut it down. But so what we did is in 2017, we started doing screenings in the community. How do you move upstream and prevent the disease from happening in the first place? And so we started doing community screenings, and I heard there's somebody here from New Directions. And the first one we ever did was at one of their facilities in the California neighborhood, and it was a blast. It was just so much fun. Great people. So we go in and we check their blood pressure, we check their heart rhythm, we check their cholesterol, and then we calculate their 10-year risk of stroke or heart attack. And we would check their abdominal aorta, make sure they didn't have an aneurysm, and we would do that free. And so we started doing that. And we first started doing it, and we did it, and we do the screening, and we'd hand them a piece of paper. Hey, yeah, you're high risk. We didn't do anything else. And so we knew we needed to do more than that. So it evolved. And so then we started coming armed with more volunteers, and we would do a screening and then make every patient sit down with either a nurse, a medical student, or somebody and spend a half an hour being educated how to prevent and change their risk. And then we open up the Health Equity Center where we refer our highest risk patients, and then we refer now patients from these community screenings. And we've now done probably close to 500 community screenings, and we're trying to do more and more and more. Like to connect with New Directions again and do more there. It's a great opportunity for us. But so anyhow, this just shows how high risk these people are that we screen. You know, either intermediate to high risk when we screen them, it's upwards of 80%. They are intermediate to high risk. We started looking at whether their cholesterol medicine was at goal or not. And those are things that we can look at. We look at their blood pressure at their initial visit, and are they at goal? Is their diet at goal? Exercise is brutal. It's hard to get them to exercise, but we're working on that. And then we look at the change at 6 months, and we look at a change in year. And I don't have enough time to go over all these, and I don't have a lot of data yet, but we also look at if they have a chronic cardiac condition. There are guidelines, right? They should be on this medicine, this medicine, this medicine. And we track that to make sure that they are on all the stuff that they should be on. And for the most part, we're close to 100% on everything in the clinic. And as one last thing, we worked with the Kentucky Healthcare Collaborative. If you're not familiar with them, they're a great organization. And we developed a health equity blueprint for people to use. And I would encourage you all to go to their website, read that document, sign it, and promote it. It's all about promoting race, health, equity in our community. Thank you.
Okay, his phone is singing really nice music. There we go. And how can that be fixed?
Yeah, that's a complicated question because medicine is such a business here in our community, in our country. And I can tell you what other countries do is, you know, we do a lot of procedures that don't need to be done. This will shock you, but in 30 years of doing bypass surgery and coronary stenting, there's never been a study that showed, unless you're having a heart attack or still having chest pain on medicine, that we've prevented a heart attack or death. Yet we do them. That's the difference that we treat. So one way is is putting in mechanisms to cut the utilization. But other countries negotiate price, and we don't allow that. Japan has the best model for prescription coverage. And they have a board that if you want to use their drug, you have to show its efficacy, and then you have to meet their price. And by the way, we do it in this country. The veterans do, the VA. But our insurers have sold you out, and so has Medicare. They banned Medicare from negotiating prescription price, which was a mistake and a joke. But those are some ways.
Larry, did you have a question?
Yeah, I'm Larry Sloan, doctor. You talked to a committee I was on a couple of years ago about your clinic. Tom Boner
Yeah,
suggested you. So,
yeah.
my question is kind of a double-barreled question. Which hospital is the best hospital for you to deal with? I've always heard that Louisville Hospital is really assigned to Medicaid patients and indigenous people who can't afford medical care. And the other part of the question is, what is the leading cause of heart problems?
So the answer to which hospital is the best, that's a low bar. I mean, the reality is yeah, university is supposed to be safety net, but none of them do. None of them want to see uninsured people. None of them want to see people with Medicaid. It's a struggle no matter where you go. And if you go to U of L, for instance, you don't have insurance or underinsured, they collect their money the same way everybody else does. But there's a way to check them. And every institution in our city is a non-for-profit, and they have to file a community needs assessment and how they fulfill that. And you can get that, but none of them are easy.
And I think a second question is, what is the leading cause of heart disease?
Yeah, that's a tough question in our country. There's a lot of reasons. Smoking, which is getting some better. Diet, exercise, those are probably, we have a terrible obesity problem in the country, and those are probably the major ones.
Curious, you just mentioned the hospitals, and it appears that they're growing bigger and bigger. They're building bigger facilities and more services. So
Yeah.
how does that, what is that paradigm? I mean, what is the balance there?
Yeah, I don't know. I think people are starting to get involved in this type of care. And, Norton's has done some great things. I don't know that it's the things I would have chose to do. I mean, there are a lot of safety net clinics in the communities. It's not that they necessarily need more clinics. What they need is those safety net clinics to be helped. And so redoing what somebody's already doing is more costly and doesn't help. But, those clinics do a tremendous job, and helping them is great. One of their biggest needs is specialty care. They don't. And so helping them with specialty care would mean a lot. And so there's people doing things. For instance, Baptist hired a nurse practitioner for our clinic and donated her to us. So we'll probably see 3,500 patients this coming year. So I think a lot of people they're starting to get interested and get involved. And it's just a matter of how they get involved.
So let's talk about Havahart Clinic, where you found a permanent home, I believe at
310 East Broadway.
Okay, how big is it? How many staff do you have? How do you function? Where do you get your funding, your finances?
So we have some employees. It's hard for us to compete for employees because we can't afford to pay benefits and such, but so we have probably 3-4 full-time employees and probably 3 or 4 part-time employees. And now there's myself and a nurse practitioner there. We're open 5 days a week. But we have a ton of volunteers and, we have, just this month, we had 55 volunteers, I think do 400 hours of volunteer work. The people who volunteer with us are just incredible people. And so a lot of it is that, so we'll go to screenings, we bring volunteers. We have a Saturday clinic this weekend. We'll probably have 20 volunteers there to run those clinics. So a lot of it's volunteer. And our funding, we started seeing people with insurance with the idea that maybe we could make ends meet and see more patients, and that hasn't happened. I don't get paid to be there, and trust me, I'm perfectly fine with that. It gives me some credibility with patients. I can flat out tell them, listen, I have no incentive. I'm not making any money here. But I'm proud to say that last year, we were able to see those 2,500 people, and I think it only cost us an additional $100,000, which that necessarily doesn't, it seems like a lot, but it's really not for us. And so we have people who donate. We've had some great foundations that have recognized what we're doing and have donated money. And so that's where we get the other money from. And if we have equipment costs, we'll reach out to them to help us purchase some equipment and such.
So what is your most immediate need in the clinic right now?
I am terrible at this stuff. So I would say, I don't know. I'm so passionate about what I'm doing, and I'm surprised I didn't cuss today when I get so upset about it. But by the way, it means you're smart if you cuss. So anyway, so I'm intelligent. So the answer is, any clinic like ours could always use money. But we can also always use volunteers. We can always use partners. And that's what we're big about. There's no reason to reinvent what somebody else is doing when there's other people in the community. And I've mentioned New Directions, but they're a perfect connection for us, right? We're trying to reach the population. They're reaching, why duplicate all that? And so partnering with other people in the community really helps. Like partnering with the YMCA is good for us. We've done that. Partnering with local churches is good for us. And so the answer is anything. Anybody who wants to do what we're doing and be involved in it, I love it.
And I think we'll agree that volunteer made a tremendous difference in the healthcare community, not only in the United States. So what are some of the things the government could do to improve the healthcare of the United States?
Yeah, I'm probably the wrong person to ask that question, but I believe that we need universal coverage in our country, and we're the only country that doesn't have that. And people that say that we can't afford to do it, the first thing I'd say is you're already paying for not doing it, because we're spending $80 to $100 billion a year to care for these people that don't have anything. They go to the emergency room, they get a surgery, they're still not going to pay you. They don't have the money to pay you. So we're already spending the money to do it. But more importantly, what I said in the beginning, what is 10 years of your life worth? And it may not be your life, but it's your neighbor's life. And how much is that worth? And there's not a price on that. And if other countries can do it and survive doing it and live longer, the European countries live 3, 4, 5 years longer than we do. They live healthier than we do. How are they doing it? And it's how you spend your dollars also. So I think that we need universal coverage. Everybody needs access to care. 50% of the country shouldn't have to worry about whether they can go to the doctor or not. That's a ridiculous statistic. It's just stupid. And so I think that that's one of the things that we really need to do in this country.
Thank you so much.
My
for coming.
pleasure.
Yeah.
Thank you, guys.
Thank you, President Jean. Next week's meeting will feature Ward Wilson from the Kentucky Waterways Alliance. The menu will be jambalaya without shrimp and garlic bread, and a vegetarian gluten-free option is available upon advance request. If you would like to attend, please RSVP by 4 p.m. tomorrow. Scan the QR code at your table now to register. Our Business Synergy Networking event at the incredible new Watch Hill Proper Bourbon Club in Norton Commons was a great hit, with a dozen guests in attendance in addition to Rotarians. Colleen Thomas from the Kentucky Distillers Association shared an industry update, and co-owner Tommy Craggs led a bourbon tasting. You can see more photos and a video on our Facebook page. An honor flight for Kentucky and Southern Indiana area veterans of the Korea and Vietnam Wars will be returning to Louisville International Airport on next Wednesday, April 20th, around 9:15 p.m. It will be a memorable day for these veterans, and we hope that you'll plan to join the crowd to cheer and greet them upon their return. It's a wonderful evening. You will not forget. If you've never done it, please join us for that. For more information, contact Jerry Martin. March was Women's History Month, and we overlooked recognizing our 4 female presidents. We'd like to honor them and all of our female members. Please review the weekly Sparks email for more details about these events, important announcements, and this week's birthday celebrations. Thank you, President Jean.
Thank you, Molly. And as Susan indicated, women were not allowed in Rotary until 1983. So past President Julie Schmidt, did please stand, be acknowledged. Yeah. And is Alice here? President Alice Bridges and Marilyn Orsini. All right, guys, thanks so much. Please take a postcard from your table and sign up to join us for the fantastic fun Earth Day activities next week. Thank you all for coming. This meeting is adjourned.